I can't see your screen. Okay, now a 40, oh, okay. A 42-year-old, it cannot be highlighted.
No.
Okay, that is the problem of a 42-year-old woman gravida to 42-year-old woman gravida to para to comes to the physician requesting weekly contraceptive advice. She is not married, but been she has been with her same partner for the last 8 years. She has been decided that the family is complete. She has smoked a pack of cigarettes for 20 years. She is 5 feet 5 inch tall. Weight is 59 kg. BMI 22. Her blood pressure is 130 by 80. Which of the following contraceptive method is most likely contraindicated? OCP is contraindicated, isn't it? As he is a smoker.
Mm-hmm.
Uh,
Ready?
yes.
Miss OCP. Many methods of contraception exist, including temporary and permanent option, hormonal and non-hormonal devices, oral medication, injections, implants, and ovulation tracking. The most appropriate contraceptive method is dependent on the patient and her goals of care. OCPs are a temporary form of birth control that must be taken every day. They commonly include combination of estrogen and progesterone, although progesterone-only options are available. OCP works to prevent pregnancy by thickening the mucus, cervical mucus, thinning the endometrial lining, and decreasing ovulation. While effective in preventing pregnancy when taken as instructed, there are important contraindications to prevent cardiovascular death and DVT. Pertinent to this patient, OCPs are contraindicated women who are more than 35 years old and smoke at least 15 cigarettes daily. They also contraindicated in patients with increased risk for cardiovascular events like hypertension, ischemic heart disease, valvular disease, diabetes, with endocardial damage, history of stroke or other thromboembolism, cirrhosis, migraine with aura and breast, malignancy with estrogen or progesterone receptor positivity. Okay, next. Wait. Oh,
A 20 a 38-year-old woman gravida to para 1 26 weeks of gestation comes to the physician for a routine prenatal visit. At 11 weeks of gestation, she underwent chronic villus sampling, which showed a 46XX karyotype. Her first child has Down syndrome. The patient's immunizations are up to date. Our only medication is prenatal vitamin. Our pregnancy has been complicated by asymptomatic bacteriuria with strep agalactiae. Was treated at 12 weeks of gestation with ampicillin. Was treated 12 weeks of gestation with ampicillin. Examination shows the uterus consistent with size of 26 weeks of gestation. Maternal blood group is B, Rh negative. Rubella antibody titer is non-immune. A repeat urine culture is negative. Which of the following is the most appropriate next step in the management?
mm,
Okay.
okay. So is administration of Rh immunoglobulin if antibody screening is negative at this visit. Rh, where is it? RD Negative mothers are at high risk of developing anti-Rh antibodies is exposed from blood from Rh-positive fetus, which most commonly occurs during delivery, although it can occur during prepartum bleeding or invasive procedures such as amniocentesis and chorione's veil assembly. If Rhd antigens from the fetus enter the maternal circulation, it's possible for the mom immune system to form antibodies against the Rh antigen. While this carries no significant complication with the initial exposure, subsequent pregnancy with Rh positive fetus can result in hemolytic anemia of the newborn, as maternal antibodies cause hemolysis of fetal RBCs when they cross the placenta. Rh immunoglobulin ROGAM acts by binding to Rh positive cells that enter the maternal circulation, preventing the immune system from developing antibodies. Administration of ROGAM is typically performed for Rh negative moms at 28 weeks of gestation, along with um, following the delivery of a Rh positive newborn. Any invasive procedure like amniocentesis or chorionesis and any episodes of fetal maternal bleeding. Um, Rh immunoglobulin is ineffective in a patient who already has developed the antibody. Thus, this patient antibody screening is negative. If this patient antibody screening, she should receive the immune globulin at her 28 weeks gestation visit.
Why it is not E?
She Okay, it is not E. Where is E? Where is okay? Repeat urine culture now and during the third trimester is not necessary. While bacteriuria and UTI can lead to obstetric complications such as preterm labor, screening for asymptomatic bacteriuria is recommended only once in early pregnancy. This patient has received appropriate antibiotic therapy for her asymptomatic bacteriuria. Repeat testing with urine culture should only be done for symptomatic urethritis, cystitis, or pyelonephritis.
So if we don't know that is if antibiotic does not respond even if you give the antibiotic, so on that case we don't need to do the culture.
What do you mean?
Like if somebody has group B streptococcus infection and you give antibiotic,
Mm-hmm.
af and you don't know what's the status after giving the antibiotic, that the asymptomatic bacteria is like the group B is killed or not, then
Oh,
we
I get
should.
what you're saying. But look at the question. It says repeat urine culture is negative. So they already checked.
Okay, repeat it. So as they have already checked, so in the last trimester we do not need to do again as it
No,
is. Okay.
you give the medication and then you check. Once you give the medication, yes, you have to check that it's negative, but they already checked. So why would they check again in the third trimester?
Okay. Yes, what you are talking,
Mm-hmm.
like
And
you
then,
are you are talking
uh,
about option B.
sorry.
You want to
No, I
add
was,
something?
yeah, I want to see, wanted to know, see. An vaginal culture for Strepa galactiae at 36 weeks gestation is routine. However, it's not necessary in this patient as she has already tested positive for agalactin in her urine earlier in this pregnancy. Thus, she should receive prophylactic antibiotic therapy during delivery to prevent fetal infection.
Oh,
Okay, so I guess you still give, even if she
antibiotic.
tested negative, you still give it prophylactic, but during delivery.
Okay, as he has already positive group B streptococcus previously, so we have to give antibiotic. Give antibiotic. Okay.
Mm, okay, I think that's what they're saying. Yes.
Yes.
Yeah. Yeah. I think that's what they're saying. Yeah.
Next,
Okay.
an 82-year-old woman. An 82-year-old woman comes to the physician because of 3-month history of urinary urgency. During this period, she has noticed that the toilet paper is blood tinged after urinating. At times, she loses small amount of urine unrelated to any precipitating events. She has a strong urge to urinate all the time. She voids small amounts every 30 minutes. She voids small amount every 30 minutes during the day and awakens approximately 2 times nightly to urinate. A photograph shows a genitalia. Photograph of the genitalia is shown. The remainder of the examination, no abnormality. Urinalysis shows no RBC, WBC, or bacteria or protein. A gram stain of urine shows no bacteria. Which of the following is the most likely diagnosis?
I don't know.
Okay.
Okay. So it's urethral cancer. I'm thinking, or is it the other one? It's the one in yellow, right?
Yes, yes.
The other one in yeah. Okay, so it's urethral carcinoma. This patient with symptoms of overflow urinary incontinence, unprecipitated urine leakage, inability to empty the bladder, secondary to obstruction from a large friable mass near the urethral opening. Most likely has urethral cancer overall. This is a rare cancer that is more common in men than in women. In women, it most commonly presents with lower urinary tract symptoms such as dysuria, dyspareunia. Evaluation should include a full physical exam, including bimanual exam, laboratory studies to rule out UTI, and further imaging such as CT or MRI or cystourethroskopy. The most common type of urethral cancer in women is squamous cell, and treatment includes resection as well as chemoradiation or radiation therapy depending on the extent of disease. Risk factors for this developing include age, the presence of chronic inflammation or urethral diverticulum, and HPV. Okay, I don't think I had any other. Yeah.
Okay.
Mm-hmm.
2 days after undergoing cesarean delivery, because of failure to progress, a 27-year-old woman, Gravida 1, Para 1, has mild chest pain and dyspnea after walking to the nursery to see the newborn. Her pregnancy had been uncomplicated. She has a history of serious illness, takes no medication. Her temperature is 100, pulse is 110, respiration 28, blood pressure 140 over 80, pulse oximetry on room mirror shows oxygen saturation 90%, physical examination shows clean, dry incision, cardiopulmonary examination shows no abnormality, the abdomen is moderately tender, pelvic examination shows moderate lochia. Which of the following is the most likely?
Ready?
Yes.
CLC scan of the chest. This patient acute onset dyspnea and chest pain, tachycardia, tachypnea, and hypoxia are highly suggestive of pulmonary embolus. A minority of patients with PA present with mild fever, which can create a diagnostic confusion. ECG commonly discloses sinus tachycardia without ST segment depression or elevation. The pregnancy presents a hypercoagulable state during which coagulation factors 1, 2, 7, 8, 9, 10 are overexpressed, while the anticoagulant S is underexpressed. Similarly, hormonal changes and compression by the gravid uterus lead to venous stasis and pooling of blood in the lower extremity and pelvis, common sites of venous thrombosis. Gravid patients are therefore at increased risk of DVT and subsequent PE throughout pregnancy and in the postpartum period. Further evaluation should be performed to confirm the diagnosis, preferably with a spiral CT angiograph of the chest. For gravid patient, nuclear medicine ventilation perfusion scans of the lungs are preferable because of the lower um, amount of fetal radiation exposure. Okay. Next.
Yes, a 27-year-old woman gravid to para 1, 16 weeks of gestation, comes with a physician because of moderate pain with urination. Moderate pain with urination for past 2 days. She has no history of serious illness. Pregnancy has been uncomplicated. Examination say uterus consistent with size, and a 16 weeks of gestation urine culture is greater than 10,000 colonies per ml. Group B streptococcus sensitive to penicillin in addition to the antibiotic. Which of the following is the best thing?
Ready?
Yes,
Okay, so it is maternal antibiotic therapy during labor. UTI often presents with dysuria, frequency, urgency, or suprapulmonary dysfunction, most commonly because of ascending migration of enteric bacteria through the urethra. E. coli. Example, E. coli. When untreated, this can ascend further and cause pyelonephritis or bacterial infection of the kidneys. This is characterized by fever, leukocytosis, nausea, vomiting, CV, tenderness, while group B strep frequently colonize the urethra, vagina, and rectum. It rarely causes infection in immunocompetent adults. In pregnancy, however, infection with GBS is not uncommon. Pregnant patients can develop asymptomatic bacterial cystitis, pyelonephritis, chorioamnionitis, endometritis linked to GBS. Maternal colonization and infection increase the risk of neonatal transmission. Therefore, pregnant patients are screened with urine culture early in pregnancy, and then an vaginal swab at 36 to 38 weeks gestation. So early in pregnancy, and then again at 36 to 38 week gestation. If either of these are positive or the patient develops GBS infection during pregnancy, they should be treated with intrapartum antibiotic therapy during labor to prevent neonatal transmission. This is important as GBS is leading cause of neonatal sepsis, which is associated with significant morbidity and mortality. Okay, so you screen first prenatal, then you screen at 36, 38, and then if any is positive anytime you treat, you double check after you treat that is negative, and then you give prophylactic antibiotic during labor. Got it?
yes.
Okay.
So why we haven't done like screening at 35 weeks of gestation?
What do you mean? So why is not A? You want me to
Yeah,
read A?
yes.
Okay, okay. What is it? A screening group B infection at 35 week gestation or screening group B infection at the onset of labor is not recommended as this patient currently has a known GBS infection. Screening will likely be positive even after appropriate antibiotic therapy, as colonization with GBS is common. Because of her infection during pregnancy, this patient should be treated with antibiotic therapy to prevent neonatal transmission, regardless of a screening result.
Okay.
Mm. Okay, you got it?
Yes.
Okay.
A 33-year-old newly gravid woman comes to the physician for premarital examination. She has increased cramping with menses over the past 6 months. Mens occur at regular interval with occasional spotting. Mens occur at regular interval with occasional spotting. Before onset, she has had occasional dyspareunia. She has had occasional dyspareunia over the past 9 months. Pelvic examination shows normal external genitalia, vagina, and cervix. The uterus is firm. The uterus is firm, anterior, and normal sized. The ovaries are palpable bilaterally and normal sized. Two 1 centimeter tender nodule are palpated in the right uterosacral ligament. The patient is at increased risk of which of the following? Isn't it endometriosis, the diagnosis?
Mm-hmm.
Okay.
Okay. So the answer is, oh, let me see. Infertility. Infertility is the most common complication of endometriosis or the presence of ectopic endometrial tissue outside the uterus. This ectopic tissue may occur close to the uterus, such as on the cervix, within the fallopian tube, on the broad ligament, on the ovary. It may also be distant, such as the visceral peritoneal surface of the intestines or rectum, within the peritoneal cavity, or within the thorax. Endometrial tissue remains hormonally sensitive, and symptoms often fluctuate on a cyclic monthly basis as the tissue progresses through the histologic phases of proliferation and secretory endometrium, then sloughs during menses. Symptoms include chronic dysmenorrhea, dyspareunia, dyschezia. Pelvic exam will often show tenderness of the uterine wall and surrounding structures with possible uterine immobility secondary to pelvic adhesions. Endometrial implants on the cervix or vaginal wall may also be seen. Okay. Infertility may occur as a result of tubal obstruction or architectural changes from chronic inflammation and scarring. Sorry, the diagnosis of endometriosis is definitely made to laparoscopy to visualize and sample endometriotic implants. It's not easy. Recurrent happens before 20-week gestation, which commonly presents with acute vaginal bleeding and camping. These factors include age greater than 35, prior fetal demise, uterine anatomic distortion, diabetes, thyroid disorder, whatever. While endometriosis can cause infertility, it less commonly causes spontaneous abortion. Okay.
Okay, 52-year-old woman comes to the physician because of 3-month history of severe groin pain. Initially, the pain has occurred only Initially, the pain has occurred only with activity, but now is constant and awakens her at night. She does not have pain in any other location. During the past 6 weeks, she has had decreased appetite, resulting in 4.5 kg weight loss. She has no history of injury to the groin area. Her only medication is ibuprofen. Of the left hip range of the motion of the left hip elicits pain, sensation, and motor function are intact. Distal pulses are 1 plus. Texture of the pelvis and the left hip show a poorly defined mixed lytic lesion in the femoral lytic and blastic lesion on the femoral neck and intertrochanteric region. The whole body scan shows an area of uptake in the ribs, spine, left proximal tumor, which of the likely site of the operation. Mixed lytic and blastic. Is it small cell lung cancer or colon?
Mm,
Mixed is breast. Okay.
ready?
Yes.
So it's breast. Breast cancer is the most common non-dermatologic malignancy in women and commonly presents with breast mass, skin or nipple retraction, or axillary lymphadenopathy. However, it may be asymptomatic and diagnosed on skinny mammography. More rarely, it may be found because of symptoms of metastasis, and in this patient, the most common sites of metastasis are bone, liver, lungs, and brain. When breast cancer metastasizes to bone, it causes mixed lytic and blastic lesion that can lead to bone pain and pathologic fractures. Red flags for red flag symptoms for metastatic bone disease include rest pain and pain that awakens the patient at night. In addition to an intention or weight loss, these factors for breast cancer development include exogenous estrogen administration, family history of premenopausal breast cancer, genetic BRCA1, BRCA2, early menarche, late menopause, nulliparity, obesity, African American ethnicity, a family history of multiple first degree relatives, particularly when the relatives are premenopausal. Diagnostic greatly increase the risk. In patients with early stage breast cancer, treatment consists of surgical removal of the tumor and axillary lymph nodes along with adjuvant systemic hormonal therapy, biologic therapy, or chemo, which depends on the estrogen, progesterone, and HER2 receptor positivity of the cancer. Patients with advanced breast cancer are typically treated with life prolonging palliative systemic therapy only.
Okay. A 28-year-old woman, a 28-year-old woman comes to the office because of 1 week history of malodorous vaginal discharge. 1 week history of malodorous vaginal discharge. She has not had abdominal pain. She has not had abdominal pain, pain with urination, fever. Her last menstrual period was 1 week ago. Mens occur at regular 28 days of interval, last for 3 days. Flow is normal. 3 months ago, she had vulvovaginal candidiasis that resolves after treatment with cotrimazole. Her only current medication in combination with oral contraceptives. She is sexually active with two male partners. They use condoms inconsistently. Her temperature is 37, pulse is 72, blood pressure 120 by 80. Abdominal examination shows no abnormality. Pelvic examination shows a moderate amount of homogeneous gray white discharge in the vagina, and the vagina otherwise appears normal. The cervix appears normal. There is no cervical motion. Uterine or adnexal tenderness. The adnexa are not enlarged. Wet mouth preparation of the vaginal discharge is performed, adding KOH with a fishy odor. Microscopic examination shows blue cell, no other abnormal cell noted. Which of the following is the most appropriate next step? Okay.
So it is, where am I? Intravaginal metronidazole for the patient. Bacterial vaginosis is common gynecologic condition characterized by shift of vaginal flora and overgrowth of bacterial species, commonly Gardnerella vaginalis. Gardnerella is gram variable facultative bacterial vaginosis presents with gray thin malodorous vaginal discharge. Vaginal pH is increased greater than 4.5, and fishy odor detected on KOH testing. Identification of closet or wet mount preparation is most appropriate confirmatory test. Metronidazole is first-line therapy and may be delivered orally or intravaginally. Bacterial vaginosis is not STI, and treatment of asymptomatic sexual partners is not recommended.
Okay.
Next.
Where is, like, in which line about the partner?
What do
Okay.
you? Okay.
Like she's sexually active, two male sexual partner. The
Uh-huh.
partner the partner is not infected, like she is infected.
Why you say that?
Okay, it is not STI. So if the patient comes with the symptoms and we found the clue cell, So we need not to find the partners as like STI. You got my point what I'm talking about.
No.
Like if it is trichomonas, then we will,
Mm-hmm.
or if it is gonorrhea, then we will
Mm-hmm.
give the antibiotic to the partner also, isn't it?
Okay. Mm-hmm.
But as it is not STI, so we should not search for the partners.
Yes. Now, if the patient comes and say my partner also has been having the same symptoms, whatever, whatever, then
Okay,
yeah, treat the
then
partner.
okay. A 32-year-old woman, 32-year-old woman, gravida 5, para 4, 33 weeks of gestation, admitted to the hospital because of 2 hour history of vaginal bleeding. She has not had pain, fever, or contraction. She had sexual intercourse 2 days ago. She had received no prenatal care. She had received no prenatal care. Her first pregnancy ended in uncomplicated spontaneous vaginal delivery at term. Her other pregnancies ended in elective repeat cesarean delivery. She takes no medication. A pap smear 2 years ago was reported as atypical squamous cell of undermined significance. Atypical squamous cell of undermined significance. Human papilloma virus testing at the time was negative for high risk type. She uses cocaine socially. She does not appear to be in distress. Her temperature is 99, pulse 80, blood pressure 140 by 90. Abdomen is soft, non-tender. Fundal height is 34 centimeter. The fetal heart rate is reassuring. No contractions are detected on tochometry. There is small amount of red vaginal bleeding. There is small amount of red vaginal bleeding. Which of the following is the most likely diagnosis?
Between
She has none.
placenta previa and vaginal laceration.
HPV is negative. She has. Okay,
Mm,
pick one.
okay. Feel like it's vaginal laceration. Oh, placenta previa. Okay, placenta previa refers to the abnormal positioning of placenta tissue, such as the placenta partially or completely overlies the internal cervical os. It most commonly presents with painless third trimester vaginal bleeding. How many weeks she is again? Frequently, it is detected on prenatal ultrasound, but it may not always be evident. Okay, she has no prenatal care. This patient who presents with vaginal bleeding after 20 weeks gestation should not undergo digital cervical exam until ultrasound has been performed to determine the exact position of the placenta, because severe hemorrhage can occur if a placenta previa is present. Risk factors for placenta previa include causes of uterine scarring, such as multiparity, previous C-section, and prior dilation and curettage. While it may self-resolve as pregnancy progresses, is present in the late third trimester requires careful management. Treatment of an initial bleed without significant hemodynamic instability necessitates IV administration of fluid and observation. Patients who are able to be stabilized may be experimentally managed with a plan for C-section around 37 weeks to allow time for sufficient fetal development. A C-section delivery is indicated to prevent significant hemorrhage, maternal fetal complications, and potential fetal demise. Immediate C-section is advised for patients who present in labor or those with um, hemodynamic significant bleeding. It is not
Vaginal
vaginal
laceration.
laceration is a common, yeah, is a common cause of postpartum hemorrhage. It can also occur after sexual trauma or rarely during consensual intercourse. This patient has not reported history of sexual trauma and had intercourse 2 days ago. Vaginal laceration is thus a less likely cause of a persistent vaginal bleeding.
Okay.
Hmm. So why is not vaginal laceration? Because what?
No history of no reported history of sexual trauma or intercourse,
She just
uh,
had intercourse 2 days ago.
but no trauma history. And vaginal intercourse cannot cause persistent bleeding. Like in the placenta previa, there is painless bleeding persistently. Like you, somebody's sleeping and she got up and found that her whole uh, bed is full of blood. That is placenta previa.
Okay.
And vaginal, if it is laceration, there may be mild bleeding and painful, maybe, probably.
So yeah, that'll be painful. Okay.
Okay, a 62-year-old woman, uh,
Next.
62-year-old woman comes to the office because of temperature 101 for 5 days and intermittent watery vaginal discharge for 2 days. The discharge is worse during the day when standing. She underwent a vaginal repair and hysterectomy 2 weeks ago. She has no loss of urine. She has no loss of urine with coughing and sneezing. Which of the following is the most likely diagnosis? Fevers.
Rectovaginal retroprolapse. Retroprolapse. Mm. Vaginal volvulus. Vesicovaginal. Mm.
Okay.
Okay, so the answer is vesicovaginal fistula. Vesicovaginal fistula can be a consequence of a gynecologic surgery. Vesicovaginal, okay. Gynecologic surgery, pelvic pathology, radiation therapy. It occurs when a tube opens between the bladder and the vagina and results in painless, usually asymptomatic urinary leakage from the vagina that is often worse with standing. Less commonly, symptoms may include fever if the fistula develops as a result of infection and inflammation, or if infection is a result of the fistula. GU examination will show a pool of urine in the vaginal canal, but the fistula may be too small to be seen. Confirmatory testing entails infused dyed sterile fluid into the bladder, then evaluating the vagina for the presence of the dye. Complications include increased risk for cystitis and ascending UTI caused by transmission of vaginal flora. Treatment of vesicovaginal fistula involves surgical repair and antibiotics to prevent or treat infection. It's not, it was between B also and BDF.
Okay.
It's not cystocele. It's common in multiparous patients due to weakness of the pelvic floor, which causes the bladder to collapse into the anterior vaginal wall. It's associated with stress urinary incontinence or loss of urine with increased abdominal pressure, coughing or sneezing, which this patient does not have. So cystocele. Now the erythroprolapse and urethrocoel um, occur when the urethra prolapses to the external urethral opening itself or into the anterior vaginal wall, respectively. So urethral prolapse in itself or urethrocoel. Urethral prolapse is when it prolapses in on itself, and urethrocoel is when it prolapses on the vaginal wall. Due to the loss of proximal support, most commonly in multiparticipation, they present with stress incontinence, and the urethra will be visible at the external urethral opening or palpable at the vaginal wall. On physical exam, neither will cause watery vaginal discharge. It is not vaginal vault prolapse. Occurs secondary to pelvic floor dysfunction and weakness. This weakness causes herniation of the vaginal vault through the vaginal and vaginal opening and presents with heavy sensation in the pelvic area, urinary incontinence and constipation or difficulty initiating bowel movement. It will not present with painless clear vaginal discharge. Okay, got it.
Okay,
Next.
next. A 23-year-old woman comes to the physician because of temperature 100 degree Fahrenheit, malaise, a multiple painful blister on the vulva, and difficulty voiding for 36 hours. She is sexually active with multiple partner. Examination shows multiple tender vesicles of the vulva, and there is 10 inguinal lymphadenopathy. Which of the following is the most likely diagnosis? Okay,
Okay. This herpes HSV. Genital infection is a STI infection that is characterized by painful vesicles in the genital area, vulva, vagina, cervix, perineum. Most cases of genital herpes are caused by HSV2. However, HSV1 has also been associated with genital herpes infection. Herpes genitali typically begins with pain and paresthesia, followed by formation of vesicle, which lies and progress to shallow, round, painful ulcers with a red border. The painful rash can be exacerbated during urination, in which acidic urine passes over the vesicles or ulcers. The erosions are also frequently accompanied by fever, chills, and inguinal lymphadenopathy, which is tender also. HSV is treated with a cycle wave, which decreases the duration of viral shedding and symptom. It is not chancroid. It's caused by Haemophilus ducreyi. It commonly begins with red papule that progresses to pustule and finally to a painful ulcer. Ulcer is typically exudative and accompanied by significant inguinal lymphadenopathy. I don't know if that one is tender or not. In contrast to herpes genitalis, it more commonly causes a single lesion, okay, rather than multiple small lesions. Okay, got it. Is the lymphadenopathy in Ducrey also painful?
maybe yes.
Okay, get it. Next.
One day after undergoing cesarean delivery for an arrest of dilatation, a 32-year-old woman carried a 1 para 1, temperature is 100, mild shortness of breath, she received prophylactic antibiotic at delivery, temperature 110, respiration 14 per minute, blood pressure 110 by 72, breath sounds decreased bilaterally, no rhonchi, wheezes, crackles are heard. Medical examination of the breast shows no engorgement or tenderness. Moderately tender Abdominal examination show moderately tender fundus. The surgical incision is clean and dry. Which of the following is the most likely diagnosis? So,
Between endometritis and atelectasis.
Breath sound is decreased
Yeah,
bilaterally.
so
Endometritis can cause that, may not be.
okay. Okay, ready?
Yes, it is that what I have sent you. Fast
Okay.
post-operative day, wind, water, wound, womb,
Yes.
wonderwell.
Atelectasis is a common cause of mild fever in the first 2 days after delivery or surgery. The term refers to the partial or complete collapse or incomplete expansion of pulmonary parenchyma. There are multiple types of atelectasis, including obstructive, passive, comprehensive, cicatricial, adhesive. It's most common in patients who are pregnant, immobile, or in the postsurgical state who are unable to produce adequate tidal volume to expand the lungs. In pregnant patients or patients who have just undergone vaginal delivery, increase intra-abdominal pressure caused by the gravid uterus pushes on the diaphragm and intrathoracic cavity, decreasing the ability for the lungs to expand normally. Physical examples show diminished respiratory effort, often with decreased breath sounds and dullness to percussion of the lung base, corresponding to the regions of non-dilated collapse, lung, and inadequate diaphragmal excursion. Mild hypoxia may be present. Pain control, incentive spirometry, and respiratory therapy with lung expansion maneuvers are key initial steps in management. It is not C and D. Let's see. Endometritis is acute, typically polymicrobial infection of the uterine endometrium and myometrium by normal vaginal flora. Typically presents with fever, significant tenderness of the uterine fundus, and mucopurulent vaginal discharge. A risk factor for development in endometritis is prolonged rupture of membranes more than 18 hours and will be unlikely in this patient. Pelvic abscess can occur as a delayed complication of chorioamnionitis, a polymicrobial infection of the fetal membrane that presents intrapartum, most commonly after pre-labor or prolonged rupture of membrane due to migration of flora um, into the uterus. An abscess will present as abdominal pain and tenderness, fever, nausea, and vomiting that persists despite adequate antibiotic treatment. Due to failed antibiotic penetration of the abscess, management involves percutaneous needle aspiration and drainage of the abscess. It's not septic pelvic thrombophlebitis, rare sequela of endometritis that can lead to local invasion and infection of the pelvic vein walls, which cause intimal damage and thrombosis. So this condition typically presents with pelvic pain and fever, which is often widely variable in course, ranging from normal temperature to extremely high. Diagnosis occurs through blood cultures. If this patient were persistent febrile despite appropriate medical antibiotic treatment for endometritis and sepsis, septic thrombophlebitis will be considered. Okay, next.
Okay, I have sent you the thing what I have told you.
I remember it was this one. Ah,
Okay,
you sent it to me somewhere. This one.
yes,
Mm-hmm.
okay. Mm, a previously healthy 32 years old woman comes to the physician because of 3-day history of vaginal spotting. Her last menstrual period was 5 weeks ago. She takes no medication, vital signs are normal. Pelvic examination shows blood at the cervix. Pelvic examination shows blood at the cervical lobes and had and a normal sized uterus. There is adnexal tenderness. Her quantitative beta HCG concentration is 1000 milli-international unit. Urine beta HCG is positive. Ultrasonogram shows a gestational sac. There is a simple cyst on the right ovary. Which of the following is most likely diagnosed?
Ready?
Yes.
It's normal intrauterine pregnancy. Normal early intrauterine pregnancy. Pregnancy is suspected when there is a missed or delayed menstrual period. Live vaginal bleeding can occur early in pregnancy after often caused by implantation of the embryo, which can occasionally be mistaken for menses. Other symptoms of early pregnancy include nausea, breast tenderness, fatigue. Physical exam may show an enlarged globular uterus. But formal diagnosis is made with urine or serum beta HCG. Beta HCG is produced by placenta and is undetectable in non-pregnant patients and doubles approximately every 2 days during early normal pregnancy. In normal pregnancy, uh, in a normal pregnancy, an intrauterine gestational sac should be visible by 5 weeks gestational age. Additionally, transvaginal ultrasound provides sufficient sensitivity to detect an intrauterine pregnancy once a beta hCG concentration exceeds 1,000 to 2,000, as in this patient. Given this patient positive urine beta hCG testing, increase quantitative serum beta hCG concentration and gestational sac. Oh, it says it shows. I read it doesn't show. Okay, a gestational sac on ultrasound. The most likely diagnosis is normal early intrauterine pregnancy. Sorry, I read it doesn't show.
Okay.
Okay, it's not B. So, yeah.
Yes.
Ectopic pregnancy is an abnormal. Can you hear me?
Yes. Yes. I can hear you. Sorry for
Okay,
interruption.
okay. No, it's okay. Ectopic pregnancy is an abnormal extrauterine pregnancy in the fallopian tube, cervix, ovary, or peritoneum, occurring in an anatomic location that cannot support the fetus. It commonly presents with vaginal bleeding, abdominal pain, and an low, abnormally low serum beta hCG, which does not follow the expected doubling every 48 hours. Okay. Additionally, ultrasound will likely show the gestational sac outside of the uterus, no gestational or no gestational sac at all in the event of ectopic pregnancy. And it's not ovarian germ tumor, includes teratoma, dysgerminoma, yolk sac, mixed germ cell. Broadly, they present with abdominal pain, vaginal bleeding, and bloating, as well as increased concentration of hormones such as beta hCG, alpha fetoprotein, and lactate dehydrogenase. A gestational sac will not be present in ultrasound, rather, a unilateral pelvic mass will be expected. Okay,
Okay.
okay. Next.
A 32-year-old woman comes to the a 32-year-old woman comes to the office because she has not had a menstrual period for 8 months. She has not had menstrual period for 8 months. She has not had hot flashes and vaginal discomfort with coitus during this time. Her last child was born 4 years ago. Menarche occurred at the age 12 years. Means occurred at regular monthly intervals until the age of 25 years. From the age of 25 years until she stopped menstruating, her periods become progressively less frequent. 2 years ago, caused her to oral progesterone caused her to have menstrual period, but an incidental dose failed to cause menstrual periods 3 months ago. Which of the following is the most appropriate next step in the diagnosis?
between B and C. Ready?
Yes.
B and C. Oh, it's not even any of them. Premature ovarian or FSH. Ovarian failure, also known as autoimmune ovarian failure or primary ovarian insufficiency, classically presents in a woman of reproductive age with an ovulation, amenorrhea, and infertility. It can also present with signs of early menopause, such as hot flashes, night sweats, vaginal atrophy. It is caused by autoimmune inflammation and destruction within the ovaries, leading to decrease in estrogen production, limited follicle reserve, and loss of ovarian stromal cells. FSH and LH concentration are increased as a result of lack of negative feedback. The secondary amenorrhea may additionally be evaluated by progesterone withdrawal test, as was done with this patient. This refers to a test in which the patient is prescribed a short course of progesterone and then is observed for uterine bleeding after its withdrawal. Progesterone therapy acts to inhibit FSH and LH, preventing ovulation, as well as to maintain the endometrial lining and cause its transition to a secretory rather than proliferative endometrium. When progesterone is withdrawn, bleeding occurs if the amenorrhea is caused by abnormality or irregularity of the hypothalamic pituitary ovarian axis, such as an ovulation. Hmm. Bleeding will
So
not
for
occur.
premature ovarian failure, we need to see serum FSH.
Yes, bleeding will not occur if the abnormal bleeding is caused by a structural abnormality of the uterus or is in the setting of, estrogen deficiency. Premature ovarian failure is most often idiopathic, but is more common in women with karyotype abnormalities or other autoimmune diseases such as Hashimoto thyroiditis. It's not B or C. Yeah, hysteroscopy will be useful in evaluating the uterus for structural causes of amenorrhea as it allows the visualization of the uterine cavity. However, it's more commonly used in the diagnosis of polyps and fibroids, which presents with irregular menstrual bleeding rather than amenorrhea. It's not measurement of serum estradiol 17 beta concentration will likely be low in this patient given her diminished ovarian reserve. This low concentration of serum estradiol is responsible for the symptoms of menopause. Yeah. However, this measurement would not establish the diagnosis of premature ovarian failure. Uh,
Okay, can you summarize
Um,
what
I
is?
guess you since
Yes,
I guess
endometrial
since
biopsy for endometrial cancer. Okay, I got it. It happens in postmenopausal women with a vaginal bleeding. Okay, next.
okay, wait, you want me to summarize what like the
All the
explanation?
options.
Oh, okay, okay. So yeah, the endometrial biopsy for cancer. So we know it's not cancer here. Hysteroscopy will be to visualize the endometrium. So for polyps and fibroids, it's not that because she will have bleeding, and here she's not having any bleeding. Measurement of estradiol is they say she has I think with the question you get that is some kind of premature ovarian follicle failure. So there's no estrogen. So the estrogen will be low. So this cannot confirm nothing. We already know the estrogen will be low. TSH, there are no other signs of thyroid, so it cannot be that. She didn't lose weight, gain weight, temperature, nothing. It's not TSH. And then we're checking FSH LH because if she has, indeed, she has ovarian follicle failure, estrogen will be low, so FSH should be high. So if we find FSH is high, then we can confirm that, okay, it's because estrogen is low.
Okay,
Does that make sense?
yes. Next,
Mhm.
you want to go for breakfast?
Sure.
It's up to you. Okay, do one question
Okay.
after 15. Okay.
Mhm.
We should uh, go through a landmark. Okay.
Okay.
10 days after the delivery of a healthy newborn, a 21-year-old woman, gravida 1 para 1, comes to the physician because of 1 day history of heavy, bright red vaginal bleeding. She also has had cramping, abdominal pain. Her temperature is normal. Examination shows firm uterus, consistent in size, with an 8 to 10 weeks of gestation. Blood is at cervical os. Which of the following is the most likely diagnosis? Okay.
Ready?
Yes.
So it is retained placenta fragments. Postpartum hemorrhage refers to blood loss associated with delivery exceeding 500 ml for a vaginal delivery and 1000 ml for C-section. In the majority of cases, PPH, postpartum hemorrhage, will occur immediately following delivery. That's primary PPH. However, it can be delayed, secondary PPH, occurring over 24 hours for up to 12 weeks after delivery. Oh, okay. So like 3 months, I guess. Yeah. The most common cause of primary PPH include uterine atony, vaginal or cervical laceration, and retained products of conception. Okay. The causes of secondary PPH include infection, bleeding from the placental attachment, and retained products of conception. Wait, same thing, retained products of, okay. While normal postpartum vaginal bleeding can persist for up to 4 weeks postpartum, secondary PPS is suggested when the bleeding stops menstrual pad in less than 1 hour or when the bleeding persists past like 8 weeks postpartum. Retained products of conception as a cause of secondary PPH may also present with fever, abdominal pain, and enlarged uterus. So she doesn't have any of that. Okay. Ultrasound would show echogenic material in the uterine cavity. Treatment includes dilation and evacuation. It's not cervical laceration is a frequent cause of PPH. It can occur during the normal course of childbirth and is suppressed surgically. It more commonly causes bleeding immediately following delivery and will be a rare cause of delayed PPH. So delayed PPH is caused by infection, bleeding for the placenta attachment or retained products of conception, and it can happen up to like 3 months after pregnancy. Okay,
Okay. Let's take a break.
okay.
Okay. An healthy, an healthy 32-year-old woman, gravida 3 para to 24 weeks of gestation. Gravida 3 para to 24 weeks of gestation comes to the physician in September requesting an influenza virus immunization. She does not smoke. She is nursing assistant at a residential facility for disabled adult. Pregnancy has been uncomplicated. Examination shows uterus consistent with size of 24 weeks of gestation. The fetal heart rate is 120. Which of the following is the most appropriate recommendation?
Hmm. Influenza immunization after the influenza season begins. Prior to influenza season. Hmm. She's at influenza September. Hmm, I don't know.
Okay.
Okay, so it's influenza vaccine virus immunization prior to influenza season. Influenza vaccines are redesigned each year to protect against a variety of different influenza strains. Thus, yearly influenza immunization is recommended for all patients. Should be given ideally prior to influenza season. Generally, like October to April in the northern hemisphere, as soon as possible if the season is already underway. The only contraindication to receiving influenza vaccine is a prior severe allergic reaction to the vaccine or its component. Additionally, children younger than 6 months old should not receive the vaccine. Pregnancy commonly causes mild immunosuppression, increasing the risk of severe disease, hospitalization, and influenza associated death. Thus, prompt vaccination against influenza is especially important in pregnant patients. The influenza vaccine comes in two forms: intramuscular inactivated virus vaccine and intranasal live attenuated vaccine. Pregnant patients should receive the inactivated version as the live attenuated carries the risk of transplacental viral vaccination. It's not D as in C as in cat. Influenza virus immunization after influenza season begins will be a necessary delay in indicated care for this pregnant patient. Vaccination should be administered before the beginning of the season or as soon as possible if the season is already started.
It
Next.
cannot be given after delivery.
Yeah, it can be given after delivery, but why are you going to wait for after delivery
Okay.
if you can give it now? Next.
A 24-year-old a 24-year-old newly gravid woman comes to the physician because she has been unable to conceive for 2 years. Mens occur at regular 28 days of interval. She has mild pain with menstrual period. She has not had pain during sexual intercourse or discharge from her breast. At the age of 18 years, she was hospitalized for management of PIDs and IV antibiotic therapy. At the time, NAT of the cervix and chlamydia trachomatis was positive. Testing Neisseria gonorrhoeae was negative. Her husband has a 2-year-old child with a previous relationship. Physical examination, pelvic examination showed no abnormality. Hysterosalpingography, bilateral hydrosalpinx, and distal tubal occlusion. Which of the following is the most likely cause of this imaging?
Ready?
Yes.
So its immune response. PID is characterized by the inflammation of the upper genital tract and pelvis from ascending migration of bacterial infection of the lower genital tract. Its clinical manifestation includes pelvic fever, abdominopelvic pain, and mucopurulent discharge, as well as cervical motion tenderness and uterine tenderness on exam. Risk factors for its development include multiple sexual partners, failure to use barrier contraception, young age chlamydia is a common cause of PID and can be treated with antibiotic therapy. Complications of PID include Fitzhugh-Curtis syndrome or perihepatitis to bovarian abscess and chronic issues with infertility caused by tubal occlusion. Tubal occlusion describes the lack of patent fallopian tube, which is caused by immune response to the infection and consequent scar formation. Despite antibiotic treatment, the fallopian tubes can fill with fluid to form the bilateral hydrosalping seen in this patient. This occlusion prevents the passage of ova and sperm, resulting in infertility.
Okay. Next, a 32-year-old primary-gravid woman, 7 weeks of gestation, is admitted to the hospital because of 2-day history of nausea, vomiting, dehydration. She has had 4-week history of generalized weakness. She has been admitted twice during the 2 weeks. Similar symptoms. She has no history of gastrointestinal illness. Her only medication is prenatal vitamin. The patient is in mild distress. Her temperature is 37, pulse 125, blood pressure 120 by 80. Ophthalmologic examination shows mild exophthalmos bilaterally. There is restrained tremor of the hand. Which of the following serum concentration is most likely?
Ready?
Yes.
So it is 3-thyroxine, so T4, I guess. The presentation of thyrotoxicosis includes diaphoresis, weight loss, anxiety, palpitations, tremor, tachycardia. Hyperthyroidism in pregnancy may occur as a result of Graves' disease, likely in this patient given herbs of ophthalmos, or can be mediated by ACG, as the beta subunit in ACG has significant homology with TSH. So it's kind of like TSH. So okay, so it works on TSH receptors, I guess. Other causes of hyperthyroidism, such as toxic multinodular goiter or toxic adenoma and thyroiditis, are less common in pregnancy. In non-gravid patients, a decrease or undetectable TSH concentration is the most sensitive indicator of hyperthyroidism. Okay, non-patient in non-pregnant patient. However, TSH can be decreased in normal pregnancy due to an increase in serum thyroxine binding globulin and stimulation of the TSH receptor by the ACG. Oh, evaluation of hyperthyroidism in pregnancy should therefore initially focus on measuring concentrations of free T4, which will be increased. Free T3 concentration will be increased too, but T4 is the precursor of T3. Measurement of T4 is preferred as its concentration will be affected earlier in the course. Once the diagnosis is established, measurement of the thyroid receptor antibody is helpful in differentiating Graves' disease and HCG-mediated causes, as it is positive in most patients with Graves' disease. RAYU scans are contraindicated in pregnancy. Patients with symptomatic moderate to severe hyperthyroidism benefit from treatment with oral beta blockers such as metoprolol or propranolol, which should be weaned as soon as thyroid hormone synthesis is controlled with PTU or metimazole. Okay.
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 Next. a, tw- a 27-year-old primary gravid woman, 39 weeks of gestation, admitted to the hospital in labor. Contractions began 6 hours ago and are occurring every 3 minutes. Her pregnancy has been uncomplicated. The cervix is 6 centimeters dilated and 100% effaced. Vertex is at 1 minus station. Membranes have not ruptured. 2 hours later, the cervical examination is unchanged despite adequate regular contraction. 3-minute interval. Which of the following is the most likely cause of this patient finding?
Ready?
Yes.
Okay, so it's prolonged active phase. Labor oh Lord, three different stages. First stage is divided into latent and active labor and encompasses the start. I told you this question, like we're gonna get this question.
You, yes,
Sure.
we will get this question 2 to 3, maybe.
We'll get this question on the exam for sure, because this is crazy.
But after
Anyway.
getting this question, our heartbeat really starts
No,
beating
at least
so fast.
I feel like during the exam, if we get those questions, these questions, kind of will be like, okay, okay, chill question, like, oof, okay, you can breathe a little bit because we've done so many of these like already.
Yes.
The first stage is divided into latent and active labor and encompasses the start of labor, contraction, cervical change until completion of the cervical dilation, so all the way to 10. Second stage is when the baby is coming down. The third stage and the placenta coming out. The first stage of labor is considered latent until like so from 1 to 4, and after which the rate of cervical dilation increases, and the patient is considered to be active labor. So 1 to 4 latent, 5 to 10 active. Prolongation of arrest of labor progression can occur through the labor process. The active stage of labor can be prolonged, which occurs when the cervix is dilated at less than 1 to 2 centimeters per hour, or arrested when there is no cervical change for greater than 4 hours with adequate contraction, or greater than 6 hours with inadequate contraction. Additionally, the second stage can be prolonged, which occurs after 2 to 3 hours, okay, or arrested. That's the second stage. If descent of the fetus fails to occur or further pushing is unsuccessful. So that's new. Second stage can be prolonged if not descent for 2 3 hours, or arrested if the descent of fetus fails to occur or further pushing is unsuccessful. Prolongation or an arrest can be caused by hypotonic contractions, cephalopelvic disproportion, and non-occiput anterior fetal presentation. Fetal birth weight, maternal BMI, and neuraxial anesthesia can also play a role. Prolongation of labor can be managed with oxytocin to augment uterine contraction and prostaglandin to assist in cervical openings, whereas rest of labor is C-section. Here, when they say prolongation and arrest can be caused by hypotonic contraction, blah, 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 do they mean the first stage or the second stage?
Uh, can you say this again?
Here, when they say prolongation and arrest can be caused by hypotonic contraction, cephalopelvic disproportion, and non-occiput anterior fetal whatever, do they mean the first stage or the second stage?
I can't say it. My
You don't
brain
know.
is not working in that
No,
ways.
okay, 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 okay. Anyway, next.
I think that it is first stage because onset of true labor pain to full dilatation. Like full dilatation is 10 centimeter dilatation, isn't it?
Okay.
And
So when
so
they say prolongation and arrest, the
this is,
contraction, all that, that's
yes.
the first stage.
And in that phase, like true labor, onset of true labor pain to full dilatation of the cervix, like 10 centimeter, on that phase, we actually see the prolongation and the arrest, isn't it? Because on that phase, we actually do the partograph. Have you heard about the partograph? Like
Mm,
the 1 centimeter opening or 2 centimeter in 4 hours and in 6 hours, they actually in our country, I don't know about US. In our country, the partograph is a one sort of like a chart, like how much uh, cervix is opened. It is measured after an hour. Like 1 hour later, do a parvaginal examination, and they actually measure through hand. That's how much the cervix is open. You got my point. What I'm trying to say.
mhm.
So
But
that, sorry.
because here it says that the second stage can also be prolonged and arrested.
Yes,
So
second
that
stage can be prolonged or arrested. Yes, these can be, but not. It is may not be associated with the like the prolong and arrest in the first stage of labor, where we actually count like
okay.
less. What is arrest? Less than 1 centimeter per 2 hours, isn't it?
Mm-hmm.
And what is protraction? Like, hmm, am I
No, you
saying
don't.
wrong?
You're
Sorry.
saying. Mm-hmm.
Protraction is less than 1 centimeter per 2 hours, and arrest is like less than 1 centimeter or less than 2 centimeter for 4 hours in
No. You,
active. Then you say it. I am
oh.
okay.
Okay.
What is prolongation? Sorry, what is
Prolongation,
protraction and what is arrest?
prolongation less than 1 2 centimeters per hour.
Okay,
And arrest no change at all for 4 hours with normal contraction or 6 hours with
inadequate
abnormal.
control.
Mhm.
Okay, no cervical change.
Okay, so this is the first stage. Okay, got it. Next.
A 23-year-old woman comes to the physician because of 4-day history of bloody discharge from her nipple. Her maternal grandmother was diagnosed with breast cancer at age 37 years. Breast examination shows bloody discharge from the left nipple and 2 millimeter nodule underneath the left areola. Which of the following is the most likely diagnosis? Bloody nipple. Okay.
Ready? Okay.
Yes. Is it inflammatory carcinoma?
Probably not. It is Dr. Papilloma.
Okay.
Doctor, let me read this. Okay, no, let me read that one. Ductal or intraductal papilloma is the most common cause of unilateral bloody nipple discharge, which may reflect malignant pathology if present in the setting of palpable breast mass. Ductal papillomata are benign tumor originating from the walls of the lactiferous duct that proliferate into the ductal lumen. The papilloma is commonly too small to be palpated but may occasionally be felt underneath the areola. Doctor papillomata can be solitary or multiple. Initial diagnosis is typically made by ultrasound and corneal biopsy. A small portion of ductal papilloma contain regions of atypical cells or ductal carcinoma in situ. Removal of the papilloma can be performed with surgical excision or micro excision of the lactiferous duct, which facilitates detailed histopathologic analysis. Okay, I cannot read the rest. It's not
Just
cystosarcoma.
read the option I. Rest of okay. Phylloids is a huge tumor, rapidly growing tumor. Phylloids. It can cause bloody nipple discharge, but it's a very huge, rapidly growing tumor. Of phylloids tumor. Okay.
Okay. And you say inflammatory
Yes.
carcinoma is an aggressive form of breast cancer that presents with inflammatory changes of the breast, like redness, edema, tenderness. It does not present with a small breast mass or bloody discharge.
Okay. Let's do some biostats.
Okay.
Okay.
Where were we at? I think we did dispersion. We were sensitivity and specificity. Oh, goodness. Okay. Wait, is this the one question? Yeah.
Okay, you start reading. I'm not
Okay.
finding my.
Okay. It's six questions though. Okay. A new test has been developed for early diagnosis of pancreatic cancer. It uses a serum marker level as an indicator of the neoplastic process. The graph below demonstrates the distribution of serum marker levels in both healthy and diseased populations. Healthy disease. Okay. Compared to the blue curves, the red curves are associated with have you found it?
Yes, yes.
Okay. The red curves are associated with
Blue, blue to red. Healthy, true negative, true negative, disease, true positive. Everybody gives their last name. False, false, false negative, blue to red. So false negative, so false positive, false decrease, false negative, false positive,
specificity
specific,
lowers.
positive, derivative, positive, less false negative, false negative, specificity very higher, specificity, sense, sorry,
True positive. Okay. Oh, okay. Didn't even check.
wait, once, just a minute.
Okay.
Okay,
Okay. Next. A new diagnostic test for TB has a sensitivity of 90%, specificity of 95%. If applied to a population of 100,000 patients in which the prevalence of TB is 1%, how many false negative results will be expected? Forgot what was the sensitivity is
true,
you have the disease and you test
false,
positive for the disease.
negative divided by true negative plus false.
Specificity is forgot false negative was where? Specificity or sensitivity?
Sorry,
False negative was part of what? Specificity or sensitivity? I forgot.
false positive, specificity,
False negative, negative, sorry.
sensitivity,
False sensitivity. So its sensitivity is this. Sensitivity will be, I guess it's true positive over false negative. So then 1% of 100,000. 100,000 times 1 and 300. That would be 1,000. And you say it's 90, blah, blah, blah. So that would be 90 over the 1,000 divided by 100. Oh, times 100. Okay. Okay. Ready?
Yes.
Okay. Rare disorder of amino acid metabolism causes severe mental retardation if left untreated. If the disease is detected soon after birth, a restrictive diet prevents mental abnormalities. Which of the following characteristics will be most desirable in a screening test for this disease?
If it is soon after birth, just if the disease is detected from rare disease. Okay.
A rapid test that is used to diagnose herpes infection is positive in herpes infected patients 9 times more often than in non infected patients. Which of the following expressions is used to derive this information? This infection is positive and blah blah blah.
Is it likelihood?
Don't know.
What the words are very confusing.
Yeah, I don't. Mm, mm-mm. I forgot what livelihood was. I know we read it last time, but it's probably likelihood. But I don't know if it's positive. Nah, probably
Positive
this
is
one.
sensitivity divided by 1 minus specificity.
Okay.
Okay.
Next, a new serum marker shows promise in the early diagnosis of colon cancer. It represents a fetal antigen that has minimal expression in healthy adults but has increasing expression in those with colon cancer. Various serum concentration levels, P1, P2, P3 are tested as cutoff points for diagnosis of disease. The sensitivity and specificity of the test at each of these serum concentration is then compared to the gold standard, excisional biopsy. The following curve is constructed. Which of the following is the best statement concerning this new test?
Okay.
38-year-old Caucasian primigravida presents to your office at 20 weeks gestation for prenatal. She's concerned about the risk of Down syndrome and asks about methods of early diagnosis. You explain that triple screening may detect up to 50% of cases and amniocentesis may detect up to 90%. She decides not to undergo either test and gives birth to a child with Down syndrome. While comparing both tests during patient counseling, you specifically emphasize what? Hmm. Sensitivity, people that have the disease and test positive for the disease. People that test positive for the disease. Like,
Okay.
ready?
Yes.
One. Okay,
We are
so
lost in sensitivity and specificity.
I am. So first is B as in boy. Got it wrong. Second is 100. I don't know where they got that. Third is A, high sensitivity. Got it. Second is okay. The fourth is sensitive. Yeah, I got it, but I guess on that one. And then this one is okay. Yeah, that was my second option. And then the last one is increased sensitivity. Yeah, I'm lost. Okay, you
Okay.
can read.
Okay. Sensitivity and specificity are measures of diagnostic test validity. Sensitivity is defined as a proportion of the disease who test or proportion of the disease who tested positive for disease. Specificity is defined as the proportion of the disease-free subjects who test negative for the disease. Sensitivity is equal to true positive divided by true positive plus false negative, A divided by A plus C. Sensitivity represents the probability of testing positive in patient having the disease. For example, sensitivity of 90% means 90 out of 100 patients with disease would be test positive. Question 2 presents a population of 100,000 with a reported tuberculosis prevalence is 1%. In this patient, the population therefore are how 1,000 cases of existing tuberculosis. The new diagnostic test has a sensitivity 90%, would identify the 900 cases but would not identify the disease remaining of the 100 cases. False negative. Similarly, in question 6, amniocentesis can detect up to 90% cases of Down syndrome. 90% patients with Downs would test positive, indicating higher sensitivity compared to triple screening. A test with high sensitivity is typically used to screen uh, because a negative test results on a highly sensitive test would rule out the disease. Negative test now. Sensitivity negative rules it out. In question 3, it is essential to diagnose as many as hereditary metabolic disease as possible because one condition has severe complication and two, it is potentially treatable if diagnosed early. Therefore, screening test with a high sensitivity is important. Specificity equal to true negative divided by true negative plus false positive. Specificity represents the probability of testing negative in patients without the disease. Question 2 presents a population 100,000 with a reported tuberculosis prevalence of 1%. In this population, there are therefore 99,000 people free of disease. The new test would be negative 95% of these people, 94,050, but would be false positive in the remaining 4,950 people. A test with high specificity is typically used as a confirmatory test because a positive test results on a high specificity test would rule in the disease. Positive test rules it in specificity, positivity rules it in spin. I don't know what they're talking about. Okay, a diagnostic test with perfect validity would have sensitivity and specificity equal to 1, but this is seldom possible. Typically, there is a trade-off between sensitivity and specificity. Imaging a serum marker is used in the diagnosis of an oncologic disease, as in question 1. If the serum level of the markers is measured healthy and diseased individual, there is almost all an overlap the healthy individual with high normal value and diseased individual with a low normal value. If the cutoff is set as X point, the right tail of the healthy curve represents the false positive and the left tail in the disease curve represents the false negative. The bell curves in the above diagram represent the distribution of the serum marker levels in the healthy and the disease population. X represents the cutoff value for positive and the negative test result. Point A corresponds 100% sensitivity, point B corresponds 100% specificity. Shifting of the cutoff value to towards point A increases sensitivity but decreases specificity. Shifting of the cutoff value towards the point B decreases sensitivity but increases specificity. Decrease overlap between the healthy and the disease population curve as demonstrated by the red curves compared to the blue curves in question 1 decreases both the number of the false positive and false negative. Therefore, the red curves are associated with higher sensitivity and specificity. The curve shown in the question 5 is a ROC curve, receiver operator characteristic curve. It illustrates the trade-off of the sensitivity and the specificity which is made when choosing of cutoff between for positive and negative test result. In this example, P3 point shows high sensitivity, P3 point shows P3 cutoff point shows high sensitivity and low specificity. High P3 cutoff shows high sensitivity and low specificity, whereas P1 cutoff value shows low sensitivity and high specificity. As seen in figure 4, that this means P3 is closer to is it means P3 as figure 4 this means P3 is closer to point A. P3 is closer to point A 100% sensitivity, that means to point B, and P1 is closer to point B 100% specificity than to point A. Based on these observations, it is concluded that P3 corresponds to the lower serum markers value than does P1. The area under the ROC curve represents the accuracy of the test. The number of the true positive plus true negative divided by number of all observation. An accurate test would have an area under the ROC curve close to 1 rectangular shape, whereas a test with no predictive value would be represented by a straight line. Okay, the straight line of figure number 5. Two two ROC curves are shown. Curve A has under the curve is close to 1 represents accurate test, and curve B under the curve is 0.5 lacks predictive value. Another important indicator of the performance is likelihood ratio. The positive likelihood ratio is calculated by sensitivity divided by 1 minus specificity. Positive likelihood ratio of 9 indicates that uh, a positive test result is seen 9 times more frequently in patients with disease than in patients without the disease. Unlike predictive value, the likelihood ratio is independent of the disease prevalence. Okay. Do
Okay.
you want to add something?
Nope. You can add
Sorry,
Anything? No, I cannot add anything here.
questions are not tough, but the explanation is very tough.
Yeah, I can. I cannot. I cannot.
Okay.
O- Okay. Do you want to add anything?